started. Non-contact ACL injuries commonly occur during a sudden deceleration motion with excessive quadriceps contraction and reduced hamstring co-contraction at or near full knee extension. ACL loading is even greater when this high quadriceps force is combined with knee internal rotation and or a valgus load, which commonly occurs during landing and cutting motions. It's important to know the graft choice and its implications for rehab. As this was already discussed by Dr. Carlson, I will just add a few things. With the bone tendon bone patella grafts, it's commonly associated with accelerated rehab protocols, but not always. With our semitendinosus hamstring grafts, they do result in trauma to the hamstring tendons with harvest. Therefore, the hamstrings do need to be protected for about 4 to 6 weeks. With no strengthening, we will commonly wait 6 to 8 weeks to incorporate light isotonics. This is typically not a good candidate for those real accelerated rehab protocols that include early running or pivoting activities. Therefore, running and jumping at times will be delayed up to 4 months, even longer with certain patients. And with the allografts, they will rehab faster in terms of muscle strength, but demonstrate a higher failure rate. Therefore, they're also not a candidate for accelerated rehab protocols. Critical points of the rehab, starting with phase 1, post-op days 1 through 7. So immediately post-operatively start working on restoring full passive knee extension. We know that loss of extension by as little as 3 to 5 degrees is enough to affect our patient's long-term outcomes. This can lead to osteoarthritis and patellofemoral problems. At 0 degrees of extension passively, there's really no strain on the ACL. Therefore, it is safe to work into this range. Hyperextension, on the other hand, does increase strain on the ACL. Therefore, it might not be in the best interest of your patient to push into hyperextension motions, especially this early. Commonly, we get them to 0 and just let them develop that hyperextension on their own later. This is where we incorporate supine heel props, gentle gastroc stretching, hamstring stretching based on the graft choice, prone hangs, and gentle overpressure as needed during this phase. Next, we gradually improve passive knee flexion to patient tolerance. Unlike extension, with flexion we initially go a little bit lower as pushing this too fast will increase your swelling. Days 1 to 3, we're working up to 75 degrees, 90 degrees by week 1. And again, that knowing that 0 to 120 degrees, there's really no strain on the ACL, so you can get it moving. Seated and supine 90-90 exercises, as well as heel slides based on the graft choice. We commonly don't use those with our semitendinosus, will assist in gaining that knee flexion. Next, we work to reestablish quad activation and tone through incorporation of quad sets as well as the electrical stimulation done concomitantly with exercise to reestablish volitional control and augment their own quad contraction. Based on recent literature, using this E-stim will result in a faster rate of quad circumference and torque. In addition, quadriceps directed straight leg raisers should be incorporated with close attention to extensor leg. We do know with active range of motion, the most strain on the ACL is at 15 to 20 degrees from full extension. Therefore, it's important to use that post-op brace locked in extension with straight leg raises to minimize this strain if that extension leg is present. Lastly, during this phase, restore independent ambulation. We'll get them up and moving immediately. Patients will be locked in an extension brace using crutches typically anywhere from 10 to 14 days, followed by a progression down to 1 crutch, usually down to actually no crutches by 2 to 4 weeks post-op, depending on your physician. Research has found that early weight bearing leads to better outcomes than late weight bearing. Phase 2, weeks 2 to 4. Continue to assess. You definitely need to have that full passive extension and start improving flexion past 90 degrees. This is where we're around 100 to 110 by week 2, 115 to 125 by weeks 3 to 4, around 125 or greater by weeks 4 to 6. Start building endurance with a stationary bike. However, keep the resistance light to minimize strain on the ACL, which there is some present with stationary biking. Advanced straight leg raises, start active range of motion extensions, but be cautious, 90 to 45 degrees. Bone tendon bone grafts will start your active range of motion. Hamstring curls and all grafts will work into closed chain exercises such as mini squats, a very light leg press, wall slides. In addition, get the hip and core rolling. We'll start also doing some resistive ankle motions at this time. At the end of this phase, most patients are gradually progressing out of the extension-based immobilizer. This is based off of pain, swelling, and quad control, as well as their ability to demonstrate safe gait. Proprioception will also start beginning, bilateral progressing to unilateral, potentially incorporating closing of the eyes and incorporating some of those dynamic motions. Weeks 4 to 10, this is now where flexion is progressed towards symmetrical motion compared to the contralateral side. It's important to note that patients with loss of flexion have also been found to have worse tenure outcomes based on subjective scores and radiographs. For some of our athletes who require speed and fast turnover, this might be hyperflexion where the heels are nearing the glutes. However, ACL strain does go up once you're past 145 to 150 degrees of passive range of motion. Therefore, I always say know the status of your patient's connective tissue. Some of these hypermobile athletes do not need to be pushed into these end range motions. They'll develop it on their own, and this does also include hyperextension for that matter. Stress normal gait mechanics. Recent literature has found those who demonstrate superior functional return to sport performance at 6 months post-ACL reconstruction had fewer abnormal asymmetrical gait behaviors early on. So it's important to stress this early if you're wanting their function to be pretty good later on. Now, as we start progressing the exercise program, it's important to note there are conflicting reports in the literature regarding the outcomes of closed and open chain exercise programs. However, recent studies have found closed and open kinetic chain exercises used together result in a higher percentage of patients returning to pre-injury sport levels and demonstrate reduced knee extension deficits, while others conclude predominantly closed chain exercise programs when compared to predominantly open chain programs result in less pain and better outcomes. Therefore, when advancing strength exercises, it's important to overall just be aware of how much strain you are subjecting to the ACL and the implications of increased resistance. In a closed chain, such as with leg press, squats, lunges, adding resistance generally does not increase the strain on the ACL. On the other hand, in an open chain, such as with extension, strain does go up, and it goes up proportionally to the weight applied. Starting with the quads in an open and closed chain, ACL strain is typically greatest at knee flexion angles of 10 to 30 degrees, decreasing down to no strain with the knee flex greater than 60 degrees. Therefore, if the goal is to reduce ACL strain, higher knee flexion angles of 50 to 100 degrees is actually recommended over lower angles. However, this is obviously once they are through the limitations of pain and swelling, post early stages of rehab, and obviously it's based on how their patellofemoral joint's doing as well. Therefore, squats begin at 0 to 45 degrees with body weight, progress beyond 60 as tolerated, remembering that EMG activity actually is the greatest from 50 to 100 degrees. Form is crucial. Heels off the ground increases ACL strain by 3 times. Knees past the toes increases ACL strain, whereas trunk and hip flexion reduces ACL strain. Therefore, promote that early 30 to 40 degrees of trunk flexion, which will also better facilitate the hamstrings. Progress to single leg squats and incorporate that same trunk flexion to actually have about 24% less strain on the ACL. The leg press demonstrates very low to no ACL strain. We really like the leg press with these patients. Start 0 to 45 degrees and then gradually progress to 90 to 100, ensuring control and no hyperextension. Work in sets from 40 to 90 degrees to increase EMG activity by 2 to 3 times. And it's always a good idea to perform leg press before you're getting into those deeper knee flexion angles with deep squats. Wall slides are great with minimal strain, demonstrating EMG, or greater EMG than a lunge from 0 to 75 degrees. Start bilateral, as single will increase the strain. Decline squats or step downs and forward and side lunges demonstrate low strain and can also be incorporated fairly safely. Leg extensions will usually get delayed. However, to assist with isolation quad deficits, they can be incorporated. You will want to start initially 90 to 50, 90 to 45 degrees to reduce strain. The strain of this exercise is generally greater than any weight bear exercises, so always have that proximal pad for 2 times less strain. We typically will wait 10 to 12 weeks to work into lower extension angles with bone tendon bone grafts and 14 to 16 weeks with hamstring grafts. And again, my disclaimer, always be aware of the patellofemoral joint. I understand that some of these exercises will not be appropriate if that's the case. The hamstrings are relatively protective and very important to build, as reduced hamstring strength and recruitment is related to initial and likely secondary injury. Resisted hamstring curls produce no strain on the ACL at 0 to 90 degrees and are started fairly early, around 2 to 4 weeks with bone tendon bone ACLs, however delayed obviously with our hamstring grafts. Other great hamstring exercises consist of closed chain bridging, physio ball curls, RDLs, and then later in rehab, eccentric lowering drills can be added to further build strength. The hip and core, very crucial protecting elements to the ACL. Powers et al. Found measures of pre-season isometric hip abduction and external rotation strength to independently predict future non-contact ACL injuries. Tate et al. Found reduced hip extension, especially in males, predicted increased adduction, landings, and hop testing post-ACL reconstruction. Furthermore, research studies have found that knee extension and hip external rotation strength to significantly correlate with hop test results, but only the hip external rotation strength predicted hop test performance post-ACL reconstruction. Hip strength is crucial, and we cannot stress it enough. For this group, as previously mentioned, we will stress abduction, we will stress extension, especially with our males, and always hip external rotation. And always complete this on both sides, as we know the increased risk of injury to the contralateral side. Incorporate abduction strengthening, bridging, clams, sitting, and external rotation, to name a few. Get on the multi-hip machine. It's important to watch form, correcting any lateral trunk leaning early in rehab, and teaching athletic safe postures. Further progressions include planks and physio-ball core exercises. Towards the end of this phase, progress into combination exercises, which force the core, the hip, and the knee to work together with proper mechanics. Here you can see the Palloff press hold with the single leg squat, and resisted abduction with the deadlift. So predispose your athletes to that athletic posture by working into triple flexion before being expected to run, retrogate before backpedaling, lateral lunging before cutting. So here's an example of a lateral lunge and hold. This is a great exercise with the option to use sport cord resistance or even a TheraBand. You're getting your athlete in a single limb stance while forcing control with a hold and building confidence by turning this around and having them push off that involved lower extremity. If there's no compromise of form with this, increase the complexity, add in distractions, ball throws and catches, make it more complex. Restoring proprioception is a critical, as neuromuscular control is needed not only for sports but daily functional tasks, and is a key element to restore that limb confidence. Post-ACL reconstruction, proprioception deficits will exist bilaterally. You'll be working both sides. The literature has identified that ACL deficit patients who specifically receive perturbation training demonstrate reduced knee adduction and increased activation of trunk and hip musculature during side cutting, more normalized knee kinematics when ambulating on uneven terrain, and actually return to play sooner with less episodes of giving away, and maintain their functional status longer than those who do not undergo structured perturbation training, suggesting working in anticipated and unanticipated perturbation training for those post-ACL reconstruction. Proprioception training gradually progress through each phase of rehab, eventually incorporating tilt and balance boards with distraction, or add in the perturbations that we talked about here. When your patient is ready, go ahead and work proprioception into strength training exercises. Weeks 12 to 26. This is usually the phase when we introduce very basic bilateral plyometrics and then work into linear running. It is important to know how and when to properly progress into this advanced stage, as we are now subjecting athletes up to forces of anywhere up to 8 to 10 times their body weight, if not more. This progression should not be based on a time frame, but instead on patient-specific objective criteria. For the research of Wilk and Middendorf et al., we now have suggested objective criteria to guide us through this advanced functional stage, starting with the return of light plyometrics and again, then running. Your athlete should be able to demonstrate 30 step-in holds with proper form and technique, 10 single leg squats to about 45 degrees, proper form, 70% limb symmetry with isokinetic testing with power and endurance, or as demonstrated on a 1 rep max with the leg press, and tolerance of 50 minutes of fast walking on the treadmill, no pain, no swelling, no gait deviation. If they meet all this criteria, you start with the very basic bilateral plyometrics. You'll start with forward and retro jumps, side to side, advancing to low box jumps up, side to side, then down, always watching form with landings and takeoff. We start slow and controlled. We expect the knees, hips, and trunk to be flexed. We want soft, quiet landings that are controlled with the appropriate weight shift back to the heels. This is going to be especially important for your female athletes. Your patient's tolerance of this phase is greatly determined not only by their strength and proprioception, but your ability to get them in proper form, which is going to be needed to dissipate ground reaction forces. After tolerance of plyometrics, we progress into linear running by first starting with backwards running, as quad and hamstring EMG activity is higher when compared to forward running, therefore potentially better stabilizing the knee. Once progress onto forward running, we will gradually increase the time and speed based on the tolerance and gait of your patient, and always working to control decelerations through stop and goes once you're onto that running phase. After tolerance of initial plyometrics and a running program, patients can be transitioned into more aggressive jump training programs when they achieve the criteria of 80% limb symmetry with isokinetic testing, or as demonstrated with the 1 rep max on the leg press. 10 single leg squats now to 60 degrees with no loss of balance, proper form. Appropriate form with lateral shuffles, forward sprinting, backwards running, and no compensation with deceleration. And as well as the endurance to walk and jog, or walk or jog 30 consecutive minutes based on your athlete. That might be all of a run or it might be intervals. This is where programs such as Sportsmetrics and other plyometric training programs can be initiated, which progress the speed and complexity of bilateral jumps and work into unilateral hopping. We know through Hewitt et al. The importance of a 6-week plyometric jump training program to significantly reduce the risk of re-injury, improve strength, improve muscle imbalances, and lower peak landing forces in females and males. In fact, the rate of non-contact ACLs has been found to decrease by 70 to 80% in female athletes who undergo neuromuscular training programs. We move on to agility drills when your athlete does meet the criteria of 80% limb symmetry with isokinetic testing, or again on the leg press. 30 single leg squats to 60, a 1 mile run on a treadmill with normal gait at a comfortable speed, proper form and technique with a 12-inch drop jump, and 80% limb symmetry with single leg hop test consisting of the hop for distance, triple hop, crossover hop, and 6-meter timed hop. Agility drills are going to be progressed by working into ladders, dot drills, higher level cutting, adding reaction drills, and progressing speed and complexity, and starting with controlled sport motions. Once through agility training, your athlete moves on to clearance for sport-specific training by passing return to sport criteria, which I will have you stay tuned for my next talk for that. And that is it for this one.